Dr. Mary Beckerle, CEO and Director of Huntsman Cancer Institute, thank you so much for being part of 3 Questions.
It's my pleasure to be here.
Is it possible to quantify, through the Huntsman Cancer Institute and the many medical professionals and researchers and scientists and staff, how many lives have been saved because of Huntsman Cancer Institute's existence since 1999?
Well, you know, we are making tremendous progress against cancer, and although it's not possible to quantify for any individual research institute or clinical care institute, I can tell you that we're making tremendous progress at an international level against this disease. So just since 1991, in the United States alone, we have now a 25% reduction in the death rate due to cancer, just in that last several decades. So that's really amazing. And in terms of numbers of survivors during that period, it's estimated that more than 2 million lives have been saved in the United States alone.
Wow.
So another way to look at it in terms of kind of getting a sense of our progress is to look at the total number of cancer survivors and how that number is increasing over time. So back in 1971, when the war on cancer was first initiated by Richard Nixon, in the United States we had 3 million cancer survivors. Guess what the number is now?
I have no idea. Double digits into the millions?
Over 15 million.
Oh, wow.
Over 15 million in the United States alone. So I think that's, you know, that kind of statistic is what gives us confidence that we're going in the right direction, that we're really making a difference, and it also gives us this incredible drive to address the still major medical need. Well, while we have 15 million survivors of cancer in the United States, we still lose 1 person every minute of every day to this disease in the United States. So we have a major unmet medical need still with us, but confidence from past successes to feel like we're on the right track and we're really making progress.
Last year, you testified before Congress regarding the impact of federal funding on cancer research. And at that time, it was said that we lose 1,500 Americans a day to cancer. How important is federal funding in the fight against cancer? And how do we know that when you put money into research, we're getting something useful out?
Well, absolutely, the federal funding for cancer research is essential. It is because of the investment in cancer research, largely through federal funding, through the NIH and the National Cancer Institute. The Department of Defense has a program. It's largely through those efforts that our knowledge about cancer, the basic mechanisms of cancer, has increased, and that knowledge is now being deployed to improve treatment as well as prevention and screening strategies. So the statistics that we discussed a moment ago about going from 3 million survivors of cancer in the United States all the way to over 15 million in just a few decades, that's directly due to our national investment in cancer research and the application of new knowledge from the bench to the bedside.
According to statnews.com, the National Institutes of Health budget, which partially funds Huntsman Cancer Institute, their budget has decreased more than 19% since 2003. What effect does that have on Huntsman Cancer Institute and its research capabilities, as well as those going on around the country?
Well, I mean, all of us who are working in the cancer research arena depend on funding from the National Institutes of Health, including the National Cancer Institute. I can tell you from my own experience that, you know, every year when I get my grant renewed, or every 5 years when I get my grant renewed, it comes at about the same level as it did previously, but the spending power, the buying power, has gone down substantially. So every 5 years, because of inflation.
Yeah.
So every 5 years, I get my grant renewed, and every 5 years, I have 1 less person in my laboratory working on cancer research. So it's just the investment isn't keeping up with inflation or the cost of biomedical research inflation.
So what can be done about that funding issue?
Well, I think, as a cancer researcher, I think we all need to come together and advocate for continued bipartisan support for biomedical research in general and cancer research specifically. We are at such an important point in history in terms of making a difference in the war against cancer. I mean, it's from biomedical research investments over the last several decades that we have moved from what has been the historic kind of three pillars for how we attack cancer: surgery, radiation oncology, and cytotoxic chemotherapy. That is therapy that just kills any dividing cell, sort of non-specific chemotherapy. Those were the three pillars that all of us in the cancer field used to care for cancer patients for literally generations. And now, as a direct result of our investment in biomedical research, we have two new pillars just in the last 2 decades. One is a pillar that we can call precision medicine, which is all about targeted therapy and understanding the detailed kind of molecular fingerprint of the tumor and finding a therapy that matches that specifically. And then the second one is immunotherapy, where we now know enough about the immune system to actually try and manipulate and control the activity of the immune system so that it can be better at fighting tumors.
The way we treat cancer anymore has changed a lot over the years. One of the new innovations is what's called precision medicine. What is that, and is it working?
Yes, one of the most exciting things that's happening in cancer research and clinical care today is the advent of precision medicine. What precision medicine really means is that we now recognize that there's not just one type of cancer, but literally hundreds and hundreds of different types of cancer. And we can look at each of those individual tumors and get a sort of genetic fingerprint for what has changed and what is driving that specific tumor development. The precision medicine part comes when, once we know that, we can match that to a specific targeted therapy that goes after that precise change in that tumor. And so instead of the sort of one-size-fits-all approach that we used to use in the past, which was just, we're going to try and give chemotherapy to kill every dividing cell in the body, and of course we kill the tumor, but we also have lots of really other major adverse side effects. Collateral damage. Yeah. Now what we're trying to do is recognize what is sort of the Achilles heel of the tumor, what is the specific thing that makes it really different from our own normal dividing cells, and have a therapy that's designed to tackle that specific change.
How many cancers does that work for?
It's working for quite a few now. It's working in lung cancer, colorectal cancer, breast cancer, melanoma, childhood leukemias, adult leukemias. But you have to be careful because even in the case of melanoma, for example, one of the things we learned about melanoma, which used to be just a few years ago a completely lethal disease, one of the things we learned about it is that about half of melanomas have a particular genetic change. It's called a change in BRAF, and that change makes those particular melanomas grow out of control. So we now have a BRAF inhibitor that we can give to those patients, and for those patients that have that BRAF mutation matched to that targeted therapy, they do very, very well. The other 40 to 60%, we don't have a targeted therapy. And so, what we really need, I think, is deeper and deeper understanding of the genetic changes that happen in different types of tumors, and we need to continue to work as hard as possible to identify new targeted therapies that match those genetic changes. The ideal situation would be we would have a targeted therapy that would address every single person's unique tumor type.
What is the barrier to doctors being able to use precise medicine specific to those tumors on every tumor that is known, every cancer? What is the barrier to being able to do that?
Not enough scientific research, honestly, because we don't have enough of a deep enough and broad enough understanding of all these hundreds of different types of cancers to really know what the specific changes are in every single one, and then to be able to develop a drug that actually tackles that specific aberration. So we need more science. I I really see just in the last several years that the investment that we've made in biomedical research and in cancer research has helped us really understand the kind of fundamental cell biology that underlies cancer. And it's from that knowledge base that we're able to develop innovative ways to intervene. And so if we don't understand, we can't intervene. We need more cancer research.
There are more than 200 different diseases that fit into the group of cancer. Which of those cancers are you closest to finding a cure for, and which are still vexing you?
Yeah, so I mean, there are a lot of vexing things still to be addressed in cancer, and we can talk more about that, but it's actually really hard to answer that question, what cancers can we cure and what cancers can't we cure, because of this diversity, even within a particular type of cancer. So it's not, we can't talk about breast cancer anymore. We have to talk about breast cancers. Some of those we have a deep understanding and we have a targeted therapy. Some we don't. Lung cancer. Some of those we have a deep understanding and we have a targeted therapy. In one case, there's a lung cancer that has a mutation in a gene called ALK, and we have an ALK inhibitor. But only 5% of lung cancer patients have that particular change and are really going to be helped by this new targeted therapy. So what does that mean for us? It means that in our clinics, we have 100 lung cancer patients, and we do genetic and molecular testing on every single one of their tumors, and we find only 5 or so people who we can match to this targeted therapy.
By definition, personalized medicine or precise medicine, I would imagine, is more expensive to dispense than just, general treatments that we've used in the past. Is that not the case, and isn't that a challenge in that kind of treatment?
Yeah, I think the cost of precision medicine and targeted therapies is definitely an issue that's affecting our healthcare system. On the other hand, if somebody can be treated for their cancer and survive that and be a productive member of our society for a number of years, how do we balance that return on that investment?
As we're learning more about the genetic makeup of tumors, will the day come when doctors are able to alter a person's genetic makeup or DNA just enough so that the body will actually kill the cancer cells instead of the medicine?
Yeah, this is a really interesting concept, that we actually have some capacity to recognize and kill tumors ourselves, sort of innately. And that's really the concept of immunotherapy. So as you know, our own immune systems fight infections, like bacterial infections and viral infections. Our immune system fights foreign objects. Why can't our immune system see a tumor as something that's foreign and go after it in the same way it would go after a flu virus? Right. So that's something that scientists and cancer researchers are working on very, very hard right now, and it's one of these new pillars that we're using to treat cancers. So for example, we can go in and manipulate how vigorous the immune system is working. There are brakes on our immune systems that keep us from fighting our own normal tissue all the time. And there are now drugs that will kind of take the foot off the brake on the immune system and help our own immune systems go after those tumors. So that's one strategy that's actually in the clinic already today.
Huntsman Cancer Institute has stewardship over a database of 25 million records linked to family trees, linking the family trees to clinical records. How valuable is that database, and what do you do with it?
The Utah Population Database is actually one of the most exceptional assets in the world for cancer research. We utilize that database to find families that have an elevated cancer risk, and then by mining deeply into the genetics of those families, we've been able to identify more inherited cancer-causing genes right here at Huntsman Cancer Institute than any place else in the world. And that has led to better ways to predict risk, get people to have the appropriate screening for either prevention or early detection of cancer, and also in some cases has taught us enough about the biology of that particular cancer type that we're using that to develop new treatments.
That's stunning.
It's amazing.
That is stunning.
It's absolutely the most amazing genetic database resource in the entire world linked to health records.
With all of that data, where you can identify risk factors for certain cancers, isn't that and can that not be used as a double-edged sword? For instance, if an insurance company found out that you're at high risk for colorectal cancer, they may not take you as a customer or as an insured party.
Yeah, I think this is very, very important. I think it's very important that we have national policies and legislation that make sure that people have access to health insurance and health care, even if they have a pre-existing condition like a genetic susceptibility to cancer. But look at it this other way. We know that there's a certain type of susceptibility to colorectal cancer and uterine cancer called Lynch syndrome. We have a situation in our country right now that there are probably about 1 million people with Lynch syndrome, and only about 5% of the people with Lynch syndrome know they have Lynch syndrome. So what does that mean for these people? What it means for these people is that before they were ever supposed to go in and get a colonoscopy to screen for colorectal cancer at age 50, they were already developing colon cancer at age 30. If we knew who they were, they could get colonoscopy screening and we could completely eliminate colorectal cancer due to Lynch syndrome. So I am in favor of knowledge here. I think we ought to know what the inherited risk is, we ought to let people know, and we ought to be able to give them the kind of advice that can help them to live a long and healthy life.
The state of Utah is very blessed to have the Huntsman Cancer Institute here. It is the only major cancer center in all of the Mountain West. But what about those rural areas for which going to a big cancer center is not an option? What can be done to help those people?
Yeah, I think this is an incredibly important point, and actually it's something that we at Huntsman Cancer Institute take as a very, very serious responsibility. I mean, we here in Utah, in Salt Lake City, we're in an urban environment, but most of our state is rural and frontier territory, and our surrounding Mountain West states are very rural and frontier. Frontier, less than 7 people per square mile. So this is
frontier,
sparsely populated. And we need to be able to make sure that our National Cancer Institute designated comprehensive cancer center wherewithal with respect to cancer gets disseminated throughout the entire state of Utah and beyond. And we're doing a lot of things to try and address that. We have education centers across the entire state of Utah in partnership with Intermountain Healthcare. We have Huntsman Cancer Education Centers in several of our surrounding states, giving people information about cancer prevention and care. We also have a lot of science going on about how to help patients who live far from home, far from the hospital when they're having their cancer treatment. So, for example, we have science that is exploring how can we manage symptoms for patients who are undergoing chemotherapy when they live 4 hours from Huntsman Cancer Institute. And we have new methods now that have been scientifically tested whereby we can show that if we have this intervention, it's a telephone intervention where we check in with them every single day and we monitor their symptoms. If we do that, we can reduce their hospital readmissions, we can reduce their symptoms, and really improve their quality of life.
Reduce mortality rates as well?
Too early to tell on that, but I hope so.
Huntsman Cancer Institute has 1,500 scientists, researchers, visiting investigators, doctors, staff members. I mean, all under one roof, you've got all of these IQs and egos and competing interests, and they seem to be getting along okay. I mean, you're in charge of the whole outfit. How are you doing? How difficult is that job?
Do you know what? I think when you have a really compelling mission, like the mission of Huntsman Cancer Institute, you know, people are there because they are passionately committed to that mission. They want to contribute, and when the challenge is cancer, which is a big, terrible, complex challenge, we know that people have to work together. None of us holds the knowledge or the clues to solving this problem individually. We have to work together. So the combination of passion for the mission and recognition that the only way we're really going to get the job done is by working together as a team turn us into one really big family.
How tough is your job?
Well, you know, nothing that's you know, hard is easy, you know.
That's profound. But when you have to deal with all of those very, very intelligent people and the egos that come along with them, it's natural, and their competing interests, how do you make everything all right and keep them on track to this great vision of the Huntsman Cancer Institute?
Well, I think a lot of the way we stay together as a community is based on our passion and commitment to our mission. We always say at Huntsman Cancer Institute, we are all there for one reason. And we have three principles that guide us: the patient first, united effort, and excellence in all we do. If you keep that in mind, that's all you need to do. People really are all together working on that shared goal. And I want the smartest people in the room with me working on that goal.
You have a remarkable story of how you got to where you are right now. And in fact, I mean...
From New Jersey.
Yeah, from New Jersey. They have roads and airplanes. But there isn't hardly a month goes by that people aren't calling you up and say, hey, come to work for us. I'm interested to know, tell us how you got to where you are now and what keeps you here in Utah.
Well, you know, how I got here, I think, you know, I came to the University of Utah more than 30 years ago now as a faculty member in the biology department. And I was attracted to the University of Utah because the people I met here were very creative people. The scientists that I met in the biology department were doing some of the most innovative work I had seen, just terrific. And they were also amazingly nice people. So there was something about this place that was very attractive to me, and I spent the first 10 or so years of my career in the biology department, and then I was recruited to move to Johns Hopkins, and at that time to become a department chair. And at that time I was having a little midlife crisis, I guess you could say. I kind of was seeing that I had a big lab and it was productive and going well, and I was teaching these big classes and I loved that, but you know, I was like, am I going to just be doing this for the next 40 years? I was getting this like hankering to build something and do something more. And so the Hopkins opportunity was attractive, but then people in Utah learned about this and they came and talked to me about, well, what about, you know, working to help build Huntsman Cancer Institute. They were looking for somebody who was a cell biologist, and so I was able, thanks to that opportunity, to stay here in Utah, which is my home now, and do something that was, you know, incredibly stimulating and very rewarding. And I never left because, I mean, we just have such important work to do here, and I feel like we're positioned to really make a difference.
Last year, the big blow-up between Huntsman Cancer Institute and the University of Utah saw you get fired and then rehired, and then major changes take place, so that could never happen again. I remember John Huntsman Sr. was absolutely livid when I interviewed him about this very thing. I'm interested to know, and I imagine it was a nightmare for you. I mean, this had to have been just like surreal, I would imagine. How much of a distraction was that episode from the mission of Huntsman Cancer Institute, and what did you learn from it?
Well, it was definitely a distraction, but in the end, what we came out of that distraction with, I think, was much greater clarity about the importance of having Huntsman Cancer Institute's mission remain one that was integrated research and clinical care. And I think the other thing that came out of it was, for me, an appreciation of how deep the commitment of the university and of Huntsman Cancer Institute was to really work together and collaborate into the future. And I also saw this incredible passion and energy and support from the community. And I think it made all of us who work at Huntsman Cancer Institute realize how much people here in our community value what we're trying to do. And that was, that was a really great thing to learn.
If the University of Utah had been successful in taking over total control of cancer operations at HCI, as President Pershing had suggested, what effect would that have had on the Huntsman Cancer Institute?
Well, Huntsman Cancer Institute has always been a part of the University of Utah. So I think this sort of, issue about the university versus HCI having control is a kind of an odd issue because we're part of the University of Utah. I think the thing that was most important is that the commitment to integration of research and clinical care was maintained, and I think that's important for cancer medicine. The best cancer medicine, the value that we can convey to patients at Huntsman Cancer Institute is because of the fact that we link research to clinical care. Patients know that they're getting cutting-edge care. Our scientists are studying those patients in our labs, and we're not content with delivering state-of-the-art compassionate care of today. We want to deliver the state-of-the-art compassionate care of tomorrow. And to do that, we have to have our research really well integrated with our clinical care.
So the bottom line is that it would have changed dramatically how Huntsman Cancer Institute achieves its mission, had the university taken total control the way they wanted to.
Well, the key thing is that we have been able to maintain a commitment that we're always going to have integration of research and clinical care. And if that were ever disrupted, that would not be good for cancer patients or their families.
John Huntsman Sr. has said that many of the cancers that are most vexing, the cure for those cancers may very well come from the Cancer Institute that bears his name. How optimistic are you that someday that will indeed happen?
Well, I absolutely am very optimistic about that. I mean, we have incredible talent. We have some of the brightest minds, some of the most exquisitely well-trained clinical faculty working at Huntsman Cancer Institute and working together, bringing together an appreciation of the unmet medical need from the patient to the most cutting-edge, high-technology science in our laboratories. And that's where the hope for the future really lies. We have a Nobel laureate, we have members of the National Academy of Sciences. The talent that we have at Huntsman Cancer Institute is among the best in the world. And that's what it's going to take. It's going to take great minds, great commitment, and great teams working together to tackle this disease. And we're already making lots of progress.
Dr. Mary Beckerle, CEO and Director of Huntsman Cancer Institute, thank you so much for being part of 3 Questions.
Thank you very much.